Worldwide, cardiovascular disease affects the lives of hundreds of millions. Dedicated cardio nerds everywhere are working hard to fight this global epidemic. These are their stories.
Welcome back, cardio nerds, for another exciting ACHD case. I'm here with my ACHD co-cardio nerd, Tommy Das, and we are here at Maine Medical Center to explore the beautiful rocky shores of New England. I am excited to say that we are going to hear from our friends Omkar, Cashel, Andrew, and Phil, who are all fellows at Maine Medical Center, and it sounds like they encountered an interesting case lately. So Omkar, can you tell us a little bit about yourself and maybe a little bit about Maine Medical Center?
Hey all, my name is Omkar Bedagari. I'm a second-year cardiology fellow at Maine Medical Center. I completed medical school at Larner College of Medicine at the University of Vermont, and then did my internal medicine training at the University of Florida. My hobbies include playing guitar, traveling, and seeking out authentic food. I plan on pursuing a career in interventional cardiology and critical care cardiology, and will be applying to interventional cardiology next year. Maine Medical Center is a large tertiary care center here in the beautiful city of Portland, Maine, in which we see a broad variety of critical care pathology as well as general care cardiology pathology.
Hey everyone, my name is Cashel O'Brien, and I am a first-year cardiology fellow at Maine Med. I completed my medical school at the University of New England College of Osteopathic Medical School and went on to internal medicine training also at Maine Med, and then that's where I served as chief resident as well. So outside of the hospital, I enjoy chasing after my 7-month-old son, who definitely keeps me busy outside of work.
Hi, everyone. My name's Andrew Geisler. I'm a third-year cardiology fellow here at Maine Medical Center. I will be staying around Portland, Maine for general cardiology next year. I hail from University of New England as well and did my internal medicine here at Maine Medical Center. My hobbies include skiing, golfing, anything outdoors here in Maine, keeping up with my 2.5-year-old son as well. On to you, Phil.
Hi, everyone. My name's Phil Lacombe. I'm a third-year cardiology fellow here at Maine Medical Center, and I'll be starting interventional cardiology fellowship next year down in Texas. I completed my medical school at SUNY Upstate Medical University, and then went on to do internal medicine training at Tufts Medical Center. When I'm not here at work, I like to play soccer, watch soccer, dabble on the piano, and I like to ski and do other winter activities like any New Englander.
Omkar, Cashel, Andrew, Phil, thank you guys all so much for being here and for representing the Maine Medical Center here. And we're just so excited to have you guys as part of the Cardiogenic family. Maine is a place that I remember visiting back when I was in college. I went to school up in New England, and it's just such a beautiful place. And last time I was there, it was actually a buddy of mine from college's wedding. It was at a campground in Maine. There was kayaking, there was boating. It was just everything that the place had to offer. And so I have a lot of fondness for Maine, but you guys have spent a lot of time there. You guys are the spirit of Maine in your hearts. Tell me, where are we going to go visit in Maine and talk about some great cardiology?
And can there be some lobster, please?
Exactly. So for those who don't know, Maine is nicknamed Vacation Land for the phenomenal coastline scenery that draws visitors, especially during the summer and fall. In vein of that nickname, we've decided to take you to one of our most picturesque settings, the Portland Headlight, one of the most photographed lighthouses on a breezy summer afternoon.
Well, so I can see it now. I can just see the seascape. I can see just the shore there. I can see a lobster roll in my hand, and I can already anticipate an interesting case. It sounds like there was a patient with congenital heart disease that was involved. And I know that it's not always the most common thing that we encounter in general cardiology practice. And so I'm sure it was a really great educational opportunity for you all. I can't wait to hear about it and eat some lobster.
Absolutely. So our case presents a 43-year-old female with a history of a complicated Tetralogy of Fallot repair, most recently requiring a transcatheter 29mm Edwards Sapiens valve in the pulmonic position, and ventricular tachycardia with a dual-chamber ICD, and a flutter on anticoagulation, who came to the cardiology office to reestablish care. Her chief complaint was dyspnea on exertion and lower extremity swelling, reporting an estimated 100 pounds over the last 4 to 6 weeks. She was deconditioned to the point of even requiring a wheelchair.
Wow, Cashel, she seems pretty interesting and possibly complicated, but certainly a concerning history. I certainly remember Tetralogy of Fallot being a fascinating congenital heart disease. I remember it typically is characterized by 4 main abnormalities, including right ventricular outflow tract stenosis, ventricular septal defect, right ventricular hypertrophy, and overriding aorta. There's a wide phenotypic presentation of Tetralogy of Fallot ranging from cyanotic at birth to asymptomatic in infancy, depending on the degree of right ventricular outflow tract obstruction. In the context of her current presentation, it's certainly vital to understand her surgical history. Can you tell us more about it?
That's exactly right. So when she was an infant, she underwent what's called a left-sided Thomas-Tossing shunt, which is a type of left-to-right shunt which connects the subclavian artery to the pulmonary artery. This procedure is used in cyanotic heart disease because the connection increases pulmonary blood flow, which then increases oxygenation of the systemic blood. Soon after the shunt was created, she had an RVOT, transannular patch repair, suture closure of the VSD and ASD, and closure of an anomalous right upper pulmonary vein. Then, in her teenage years, she required repeat sternotomy with placement of a 26 millimeter homograft in the pulmonary position and a 32 millimeter tricuspid annuloplasty ring and residual ASD closure. Most recently, in adulthood, due to graft failure, she developed severe pulmonary insufficiency, requiring transcatheter placement of a 29 millimeter Edwards Sapiens S3 valve in the pulmonic position.
Wow, Cashel, she certainly has a complicated history of congenital repairs. What was she like on examination when she presented to the clinic?
She was notably hypotensive at 99/75 by cuff blood pressure value obtained in the clinic. She was otherwise afebrile with a normal heart rate of 70 beats per minute, saturating 98% on room air and breathing 13 breaths per minute. On exam, she had a normal S1, but a wide fixed splitting of S2 and a 3 out of 6 holosystolic murmur at the left lower sternal border. While she was clear to auscultation on exam, she had jugular venous distension estimated at least 15 centimeters of water at 90 degrees, 4+ pitting edema to the waist bilaterally, and her extremities were cool to the touch. Her pitting edema was present despite being prescribed furosemide 40 milligrams twice daily as an outpatient, and she hadn't missed any doses of this.
Interesting, Cashel. She certainly has some concerning findings on her physical examination for possibly a low cardiac output state, given her profound edema and also her cool extremities. We later found out from her lab work when she was transferred to the hospital, she was found to have a lactate of 3.6, hyponatremia with a potassium of 116. She was hyperkalemic to 6.0. She had an acute kidney injury with a creatinine of 2.6 previously from a normal baseline, and liver injury with an AST of 88 and an ALT of 64. She had an elevated total bilirubin of 4.4. Her NT-proBNP was 4,533 and a high sensitivity troponin T of 70. She did not have a leukocytosis nor evidence of an anemia. Given our suspicion of a low output state and possibly cardiogenic shock, she was quickly admitted to the cardiac intensive care unit.
Thanks so much, Andrew and Cashel, for so much of the background on this patient. There's clearly a lot here, and I think this represents an intersection, at least in my mind, in my background, of my congenital heart disease constructs and my congenital heart disease training, and also several of the things that I think are important in adult cardiology with new patients that you encounter where you have to think quickly about sick, not sick, and concepts surrounding cardiogenic shock and its management. So, Andrew completely outlined before and did so accurately Tetralogy of Fallot, thinking about the idea of a spectrum with the 4 classic defects, which are all really driven by an anterior deviation of the spiral septum. And so you have this anterior malalignment VSD and the sort of obstruction to the right ventricular outflow. And that causes a lot of the variation in what we see in the presentation. And so the closure of the VSD and the provision of a right ventricular outflow, I think a lot of the trajectory we see in these patients is, what does that right ventricular outflow tract look like? Is there a conduit there? Were they able to construct something with a transannular patch? How much of the valve was sacrificed? How much of the obstruction was actually muscle bundles? And a lot of that dictates how much PR there is, how much RV remodeling there is. And then in my world, in the adult congenital world, we see these patients in the long term, are they suffering from symptoms associated with RV failure? Now, it sounds like this patient did have a few bumps along the road with VT and PR that necessitated the pulmonary valve replacement percutaneously. So in the back of my mind, hearing about somebody who has quickly encountered a situation where they're becoming progressively overloaded, failing outpatient diuresis, I'm fairly worried about whether or not there's something going on with the valve and the prosthesis. The lab work is concerning, lactate elevation, everything along those lines. I think you guys were right to put her in the CVICU. I don't know, Tommy, any other thoughts?
No, I completely agree. And I think it's the sort of thing where when you have a patient like this, to have a low suspicion to think this is someone sick and to bring them in, So much the story of outpatient management of congenital heart disease, it is patients who feel like, I feel fine, I feel fine, I feel fine, and then they don't feel fine. This is someone coming to your clinic and really saying that they don't feel fine. They're clinically fallen off a cliff, unfortunately. So I think appropriately, as you guys have, recognizing that she's sick and recognizing we need to get her to the appropriate level of care is really important. And I'll just echo a point that Josh made. I think learning about Tetralogy of Fallot and thinking of it as the tetralogy, the four things, but really, as he said, recognizing that all four of those defects come from the anterior malalignment of the septum, interventricular septum. That's what causes the outflow tract obstruction. That's what causes the VSD. It causes everything. So it's almost that one defect that causes four defects, but it helps you understand in three-dimensional space why these four things go together. But I think it seems like she's a sick patient, but thankfully you guys seem like you've appropriately recognized it and we're getting her into the right level of care.
Tommy, it's such an important point to say, I don't know what this patient looked like. I don't know how many times a minute they were breathing necessarily. It sounds like 13 based on the prior exam. But if somebody's breathing 13 times a minute and they're setting 98% on room air, typically in a lot of situations, you're looking at that person in clinic and you're like, that's fine. So with our patients who are young and their protoplasm allows for them to compensate substantially for what may be a very big issue, it's important to recognize how those things present and how they look in patients with congenital heart disease, as opposed to somebody who is 60 years old, let's say, and has a lactate of over 3 and a hyponatremia of 116. We feel like a lot of that's due to a potential cardiac decompensation. Just a very important thing to reflect on. Cashel, we've gotten a lot of laboratory data and we've worked through a physical exam. I think we've gotten to the point where we can start thinking about some of the cardiovascular diagnostics, some radiology. Can you tell me what you guys were thinking and worked through the initial stages in the ICU with as far as what you ordered and what the results were?
Yes, absolutely. Her EKG showed AV pacing at 70 beats per minute. Her chest x-ray showed mild bilateral congestion and cardiomegaly. Ultimately, we obtained a congenital transthoracic echocardiogram, which showed a dilated right ventricle with moderately to severely depressed systolic function. Qualitatively normal LV with moderate systolic dysfunction. She had moderate tricuspid regurgitation in the context of her prior tricuspid valve annuloplasty and ICD. Her RV pressure was approximately 35 millimeters of mercury above the right atrial pressure. While the pulmonic valve was not well visualized, the peak gradient across the RVOT was 36 millimeters of mercury with a peak velocity of 3.0 meters per second.
So thanks for that, Cashel. Now, something I will say, and something you alluded to, and I think is an important thing to consider in the context of what is oftentimes an initial echocardiogram to assess a valve like this, is that it's very important to contextualize the quality of the picture and the quality of alignment of your echo pro and sort of your ability to obtain spectral Doppler in that context. A lot of our patients with their surgical histories, their conduit or their RVOT, they do not sit in the traditional position. I've had many patients where they have a conduit that goes along the posterior portion of the sternum, and it's really impossible to get a good picture in any way, shape, or form. And so we attempt TEE, but again, that's suboptimal too. So it can be very challenging to image in RVOT. But with that, any other thoughts, Andrew?
Yeah, her EKG and her chest x-ray were not particularly diagnostic for what was going on, besides not showing a considerable amount of pulmonary edema. So our attention certainly focused on her echocardiogram and further working up her decompensated heart failure. Given her prior history of prosthetic pulmonary valve insufficiency, our assessment started with looking for any evidence of pulmonary insufficiency. Typically, the most utilized parameters to assess for pulmonary insufficiency is to look at color Doppler to see what the width of the color Doppler jet might be in the right ventricular outflow tract. The American Society of Echocardiography suggests that a Doppler jet greater than 50% of the RVOT could be suggestive of severe regurgitation. We didn't really see any evidence of this. Other quantitative parameters could look for diastolic flow reversal in the distal PA, and also looking at the pulse wave Doppler, the regurgent envelope, and looking at significant deceleration in the pulse wave envelope, which could suggest rapid equalization of pressures between the right ventricular outflow tract and the right ventricle. But as was alluded to by Cashel, we really didn't see any evidence of significant pulmonary insufficiency. As Cashel mentioned, there was a notable gradient, particularly with the right ventricular systolic pressure was slightly elevated. And also there was a systolic gradient across the right ventricular outflow tract with a peak velocity of 3 meters per second and a peak gradient correlating at 36 millimeters of mercury. Now, it wasn't the most staggering of gradients or peak velocities, and we had to go back in the literature and at least try and assess what the significance of this gradient might be. Now, there's limited data in the assessment of prosthetic pulmonary valves, given the limited number of patients who have these valves in their follow-up. Again, the ASC guidelines from 2009 prosthetic valves suggest that normally functioning bioprosthetic valves in the pulmonary position typically have peak velocities less than 3.2 meters per second and beat gradients less than 20. So she didn't quite meet those guidelines, but certainly we had a heightened suspicion that there might be an increased gradient across her right ventricular outflow tract. What did the team do next, Omkar?
Yeah, our patient was admitted to the CICU and then started on furosemide and dopamine infusions. We attempted a PA catheter placement overnight, which preceded our transthoracic echocardiogram, but were never able to achieve a PA or PCWP waveform. Our attempts were aborted with plans for further fluoroscopic evaluation. Unfortunately, the patient had significant clinical worsening in the subsequent hours, progressing to SCI stage D cardiogenic shock.
Thanks, Omkar. It sounds like, unfortunately, she's in a tough spot and pretty sick. And I just want to take a quick pause and just chat. I think that when you're in the unit, right, the congenital heart disease patient can be a really intimidating, challenging patient. I remember being the senior fellow in the unit and having patients and just trying to make sense of what's going on. How do I make sense of their anatomy? Where is connected to what? And I think just general principles when you take care of these folks in the unit, things that I've learned and things that I'm still growing in, and trying to make an initial survey of what the initial anatomy was and what the surgeries have been to correct that, because that's going to influence in some ways how you're going to determine how sick the patient is and how you're going to assess their hemodynamics, right? This patient's a great example, right? She had a left BTT shunt initially. So if you put a left radial arterial line in, you're not going to get an accurate arterial pressure. So you may falsely misunderstand how hemodynamically compromised the patient is. So knowing that kind of anatomy, knowing that kind of surgical history makes a huge difference in terms of being able to accurately assess how sick or not sick the patient is. Similarly, knowing that this is a person who has a pulmonary homograft that's then had a sapien valve put in it, it can be challenging to get an RVOT that is in no way, shape, or form normal. It's going to be challenging maybe at bedside to float a swan, despite our best attempts. Recognizing that we need this hemodynamic data, but we're having trouble getting it. What was our next move? Okay, let's see how we can get this done under fluoroscopy in the cath lab. Again, define the hemodynamics, really understand what our reason for why we're decompensating is and go from there. So I think that's the absolute right move. But always remember when you're taking care of these folks, understanding what the anatomy is, what's been done to the anatomy since then, and how that's going to influence our hemodynamic assessment in the critical illness setting is a huge, important starting point for taking care of these folks.
And the only other thing that I would also add in that context is that keeping in mind the surgical history, keeping in mind the native anatomy, like what's been done, what were the native issues, and how is this repaired? So a lot of the time we encounter patients in adulthood who had their last open heart surgery in childhood. So whenever this conduit was put in, if they were 8 years old, their chest was able to accommodate a conduit that would work for an 8-year-old. And so that means that you're not dealing with something that's large, very big, and maybe difficult to get into. Just thinking conceptually, if you guys are really, thinking about somebody who's very sick and needs a swan, and I'll take a couple shots at floating at bedside, recognizing those types of details early on may mean, listen, this is somebody that probably needs to move to the cath lab a little bit more quickly. But it's challenging. And I think that you guys were right to take it to the cath lab.
Yeah, absolutely. Indeed, she went to the cath lab next and underwent right heart catheterization. This showed elevated right-sided filling pressures with a mean RA pressure of 23 millimeters mercury, RV pressure of 69/2 with an RVEP of 12 millimeters mercury, PA pressure of 24/13 millimeters mercury with the mean PA pressure of 15, and only mildly elevated end expiratory pulmonary capillary wedge pressure of 15 millimeters mercury. A pullback of the PA conduit was performed and revealed a peak-to-peak gradient of 30 millimeters mercury, revealing a significant RV to PA pressure gradient as noted on transthoracic echocardiogram. The cardiac index was 2.1, though notably this was obtained while the patient was supported on multiple inotropes and vasopressors. Furthermore, intracardiac echocardiography demonstrated a large globular mass on the prosthetic pulmonic valve, completely engulfing multiple leaflets. A color Doppler performed of the pulmonary conduit showed flow acceleration, indicating prosthetic pulmonic valve stenosis. So this is a good time to pause and review the working differential diagnosis. Phil, what were our thoughts at this time?
So based on the clinical presentation, imaging data, and hemodynamic information we have thus far, We surmise this was a case of cardiogenic shock driven by acute on chronic RV failure in the setting of bioprosthetic pulmonic valve stenosis from this mass that's encompassing the prosthetic valve. So even prior to any workup, some of the clinical features that should key you into this diagnosis or sort of raise suspicion would be a patient with a history of bioprosthetic valve replacement who is presenting with a new murmur, new exertional intolerance, pre-syncope or syncope, or evidence of heart failure. Now, there's several causes of bioprosthetic valve obstruction, but the differential diagnosis should include what I like to call the big three. So number one is pannus formation, which is an ingrowth of tissue around the valve that can occur over time. Number two is valve thrombosis, which is also called BVT or bioprosthetic valve thrombosis. And number three is vegetation from something like endocarditis. Now, it can be challenging to differentiate between these. And so while obstruction is typically diagnosed on transthoracic echo, cardiac CT, CMR, or PET can be helpful in providing further tissue characterization and anatomical information. Some labs that you might want to consider around this time would be an INR for patients that are on Coumadin, hemolysis labs, including haptoglobin and LDH, infectious studies like a CBC and blood cultures, and of course, any of the traditional markers of CHF like an NT-proBNP. If acute bioprosthetic valve thrombosis is a strong suspicion, and this is important, if you are thinking acute valve thrombosis is a suspicion, then you should go on to perform a hypercoagulable workup for things like familial thrombophilias. Our patient was quite sick, and once the diagnosis of obstruction was made, we quickly shifted our attention towards therapeutics. Omkar, were there any interventions that were performed while she was in the cath lab?
Glad you asked, Phil. As is often the case, her chronic RV failure was caused by a structural defect, in this case, the bioprosthetic valvular obstruction. These structural defects often require either a procedural intervention in the cath lab or a surgical repair in the OR. Our patient received a balloon valvuloplasty of the pulmonary conduit. A subsequent pullback from the PA to RV revealed slightly improved peak-to-peak gradients of 19 millimeters mercury. Back in the CICU following valvuloplasty, her status improved expeditiously. She was rapidly weaned off vasopressors and inotropes in the ensuing 1 week. Our infectious disease colleagues were involved to assist with the possible diagnosis of endocarditis. However, blood cultures and serologies remained negative. A TEE was performed, however, was technically limited by poor visualization of the bioprosthetic valve leaflets in context of the patient's several prior repairs and the anterior nature of the pulmonic valve. Cashel, how did the patient progress to discharge?
Since there was some diagnostic uncertainty, she was discharged to complete an antibiotic course for the possibility of culture-negative endocarditis and anticoagulation for treatment of a potential thrombotic bioprosthetic valve stenosis. Prior to discharge, our CT surgical colleagues evaluated her for a surgical revision. Given the concern for endocarditis, it was decided to be most appropriate to reevaluate her case after completion of the antibiotics. She was discharged to rehab, ultimately in a stable condition. Andrew, I have a feeling that isn't quite the end of our story.
Oh, if it's all right, as one quick thing I was going to just chat on, and I think that this is a really great case, and we got her out of a jam in terms of getting her out of obstructive shock and getting her out of the hospital. And just as you say, Cashel, there is something lingering, or is there something still going on here? Two things I'll say is, one, when we think about transcatheter pulmonary valve replacements, and I think about the things that people can get in trouble to down the road, endocarditis is definitely one of those things, more so than some of the other valves, and especially if there's still a gradient across the valve. We go back in the CardioNerds archive. There's a great episode that Dr. Jamil Abuhusin from UCLA and Dr. Joanna Gobrio from the Cleveland Clinic talked about transcatheter pulmonary valve replacement. And part of their discussion was if you leave the lab and you still have a gradient of over 15 millimeters of mercury across the valve, you do worry that's going to put your risk of endocarditis a little higher, a fair bit higher, actually. So definitely something that I worry about for this patient. And the other thing I was just going to quickly add, and I hope people are able to go to the website and take a look at some of the pictures that the team was able to provide, especially some of the intracardiac echo. The RVOT and pulmonary homografts and conduits are so hard to evaluate, but sometimes the best pictures you're going to get is actually on ice or in a cardiac echo, because when you're directly visualizing it and directly seeing the degree of stenosis across the valve. So I think that sometimes when there is that diagnostic uncertainty, that is a tool that's in your tool chest to reach for. But agree, she's out of a jam. She's still the gradient across her valve. These are the things that I'm worried about looking forward. But it sounds like, as you guys say, there's more of the story still to be told.
Yes. Unfortunately for our patient, about a month after she was discharged from the hospital, she represented to our emergency department for dizziness and hypotension. Just 2 weeks prior to presentation, she had completed her 6 weeks total of IV antibiotics. At the time of presentation, she was notably hypotensive, and by the time of our arrival, she was already on a norepinephrine infusion of 0.1 micrograms per kilogram per minute with a blood pressure of 88/55. She was otherwise tachypnic with a respiratory rate of 26, saturating 97% on room air with a normal heart rate, and was afebrile. On examination, she again had clear lungs to auscultation, although her JVD again was elevated, estimated at 15 millimeters of mercury, while she was seated at 90 degrees. Her extremities were ice cold, and there was evidence of mottling in the lower extremities. Her ECG again was a paced rhythm, and her chest X-ray was unchanged compared to her prior. Labs at this time of presentation were notable again for a mildly elevated lactic acidosis at 2.7, a notably elevated NT-proBNP of 13,030, and now severe acute kidney injury with a creatinine of 7.4, which had previously normalized from her prior hospitalization. She was again hyperkalemic to 6.6. She did not have a leukocytosis nor anemia, and a C-reactive protein was obtained at admission and found to be less than 3.0.
So we are really fortunate here at Maine Medical Center to have an adult congenital team that is available to discuss these cases at really all times. And with this presentation, we wasted no time at all to go ahead and get them involved. We spoke with the pediatric interventional cardiologist, Dr. Donnelly, and the decision ultimately was made to take her back to the lab for a repeat right heart catheterization, which again showed elevated gradients as high as 30 for the peak to peak and a depressed cardiac index of 1.7. They repeated ICE while she was in the cath lab as well, intracardiac echo, and there was a similar appearance with this presence of a large globular mass completely engulfing the leaflets again. At this point, the team felt she was again going to require some sort of intervention. Omkar, where did things go from here?
Yeah, Phil, given her endocarditis had been treated and she remained adherent to anticoagulation, there was highest suspicion for pannus-associated obstructive cardiogenic shock. She then had a 29 millimeter Edwards Sapiens placed valve in the pulmonary conduit. Post-procedurally, ICE images showed resolution of prosthetic pulmonic valve stenosis. This was further corroborated by repeat PA to RB pullback, which showed essentially complete resolution of a pressure gradient across the pulmonic valve. She improved markedly thereafter with a short CICU course and was subsequently discharged in stable condition.
One of the things that I found particularly interesting about this case was somewhat of the lack of correlation between the degree of cardiogenic shock and the gradients that were found on her transthoracic echo at the time of initial presentation. In the setting of native pulmonary valve stenosis, the valve guidelines kind of correlate with correlating semilunar valve, the aortic valve, with peak velocities of 4 meters per second and mean gradients of 40 millimeters of mercury, which would suggest severe stenosis. In the prosthetic world and in the congenital world, there's certainly less data about what drives a hemodynamically significant gradient across a pulmonic valve. And certainly in our case, the gradients across the pulmonic valve were not terribly significant. One of the reasons certainly could be that the Doppler alignment was not as parallel as it should be. But I'm looking at the echocardiogram, there certainly was a decent alignment of our Doppler signal. One of the things that we suggested here was that given the degree of her right ventricular systolic dysfunction, which had been more acute on chronic, it's certainly possible that her stroke volume was certainly reduced on her right side. She really wasn't able to generate the flows to produce significant gradients that could really be found by echocardiography and by our right heart catheterization.
So, Andrew, I actually think it's a really great analogy to think about the concepts that I think more often think about in adult cardiology with aortic stenosis, low flow, low gradient. Aortic stenosis, there are a lot of different sort of types, and maybe the gradients didn't seem like they were lining up with the amount of severity, considering this person was in profound shock, requiring inotropes and barely hanging on. There are a few things there that I think are worth bringing up. So, number one is, I think that our history and our calculations, as they apply to echocardiography, they're much more defined for calculating aortic valve gradients, aortic valve areas, indexing the aortic valve areas in the context of a prosthesis, acceleration times. All of those things are, at least in my understanding of how echo technology was developed, for the aortic valve. What I will say is that the aortic valve, the pulmonic valve, are what we would both call in congenital heart disease semilunar valves. And just to make mention to the others, the mitral valve and the tricuspid valve are called atrioventricular valves. And so sometimes in certain conditions, we'll say the right or left AV valve, but that's beyond the scope of things here. But I would say in the context of semilunar valves and pulmonic stenosis, because it's not an uncommon occurrence in my world that you see patients who have either native pulmonic stenosis or they have a prosthesis, and the gradients are changing. They go up or down for one reason or another. Actually, one of my most memorable cases from fellowship was a patient who had a history of congenital pulmonic stenosis, came in pregnant, was unaware of her lesion before, underwent a balloon valvuloplasty after presenting with chest pain and some level of decompensated hemodynamics, went on to deliver the baby, no issue, went home, got lost to follow up, came back and was pregnant again and had pulmonic stenosis again. And we had to go through things. And so there was an echo that was performed after she had her initial balloon valvuloplasty when her gradients had decreased, but they weren't normal. But I also have to keep in mind the context of her being pregnant in that context. We had 50% more cardiac output in that context, everything along those lines. And so, I think that it would be an interesting area for research in the future. And I think it would be an interesting area for us as congenital heart disease physicians who look at a substantial amount of the cardiography to think about how we quantify changes in pulmonic spectral Doppler signals. I think there's a lot that's contextual and qualitative, but I think you bring up a very good point with the analogy. So I wanted to make mention of that.
No, that's great, Josh. And I think I love this idea of taking these concepts, and so much congenital heart disease is based on this, is we take these concepts that we are learned in pediatrics, learned in adult cardiology, and trying to apply it to these patients that are unique. Every RVOT and every tetralogy patient is going to be a little different. And every pulmonary valve is going to be a little bit different. And the loading condition is going to be a little different. The inotropy is going to be a little different. And trying to find a way to actually take a number of different things, whether they're hemodynamic data from invasive catheterization, plus echocardiographic data, plus how the patient looks and this history they're giving, and trying to put that together to figure out what's happening in front of you. All that is what makes this field so exciting and so engaging for us as fellows and as learners. I think there's so much creativity that has to be involved in adaptability, really, and both with how do you interpret the echo in the setting of the patient, how do you take the patient to the lab and figure out what the best explanation is going to be and best intervention for the patient is going to be. Because sapien valve was never designed for the pulmonary position, but that being said, was a very appropriate move for this patient. It seemed like it really helped them get out of the jam as well. So this is, I think, a great reflection of the work that you guys have done at Maine Medical Center. And it's just been amazing to hear the case that you guys have presented and presented so well. And you guys are an awesome group and really fun to chat with. And I just want to hear our classic conversation ender for these case reports is asking you guys, what makes your heart flutter about being in cardiology? And after going through that case and the care and attention you guys pay to it, I can't wait to hear what is making your heart flutter right now in cardiology.
Yeah, I think this case is a great example of what really excites me in cardiology, complex anatomy and complex physiology. And in doing so, and in caring for these types of patients, using very thoughtfully constructed procedures to manage and generate very favorable outcomes in our patients. That's really what excites me.
For me, I think I get very excited about women's cardiovascular health, and then also thinking about the areas in cardiology where there's still a lot of uncertainty. I feel like our field has so much data and so many great trials, but there's still so much more to learn. I think at the moment, the topic of MINOCA or myocardial infarction with non-obstructive coronary arteries is really fascinating and a place I'm hopeful that we'll have a lot more clarity in the future.
Hey, this is Andrew again. Running through this case again, I can picture this lady's face in my brain, and she was such a lovely lady. And I feel cardiology, and particularly the cardiac intensive care unit, is such an intersection of the highest level of technology and the humanity of everything that we do here. And that's certainly what keeps me going and keeps me excited about cardiology.
For me, the answer is physiology. It's sort of a long-winded answer, but I lived with 3 guys during medical school. And I remember when we were going through the cardiac chapter, I was struggling to understand these concepts of preload and afterload and what happens if you adjust all these different parameters for a patient. And finally, I got so frustrated. I said, that's it, guys. The cardiovascular system is a soup. I can't fully understand it. But of course it's not, right? But now that I'm a little further in my training, I've realized it makes a lot of sense, right? The physics and the anatomy is all well connected and makes sense. And so I love that all of these things that we learned throughout medical school, residency, all come together and you can really apply that to making patients feel better. I just think that's quite amazing.
And what I'll say is that this case was an excellent demonstration of physiology in action. I think it also is a statement on you guys as a team, as a program, that you recognized how sick this patient was as quickly as you did, got them escalated, got them help, and got them through. I'm very thankful that you guys did that. I'm sure this patient is very thankful that you guys did that. I just want to say thank you. Thank you for that. Thank you for bringing this case to our attention. I think there are a lot of lessons that we can take away from it. This is far from the only patient who is going to have a transcatheter pulmonary valve placed to bail out of obstruction. And I think as we see more and more of these patients come of age and work their way into adulthood, we'll encounter more and more patients with congenital heart disease in acute situations. So this was definitely something that I think we have a lot to learn from.
Great work, guys. Awesome case and awesome discussion. I got to say, the next Physiology in Action is going to be finding the next place in Maine to go get us some nice high quality lobster rolls. That's where I'm at right now.
Down with that. The heart as a soup. I love that. Maybe the soup is lobster bisque at Maine Medical Center. How's that?
Oh, that sounds delicious. I certainly can find some excellent lobster bisque around here.
And now for the ECPR segment for this episode, I'd like to introduce Drs. Bram Geller and John Donnelly. Dr. Bram Geller is a critical care cardiologist and the director of our busy cardiac intensive care unit. He completed his medical school training at University of Massachusetts Medical School before he went on to complete his internal medicine training at Brigham and Women's Hospital. He then did training in cardiovascular disease and an advanced fellowship in cardiac critical care medicine at the University of Pennsylvania. Dr. John Donnelly is a pediatric interventional cardiologist and the director of the congenital catheterization laboratory at Maine Medical Center. He completed his medical school training at the University of North Carolina at Chapel Hill, then went on to pediatric residency training at the Children's Hospital of New Mexico. He completed pediatric cardiology fellowship at C.S. Mott Children's Hospital at the University of Michigan.
Hi there. My name is Bram Geller. I'm the director of the CICU at Maine Medical Center and a critical care cardiologist, and I'm joined here by one of my colleagues, John Donnelly.
Hi, I'm John Donnelly. I'm a pediatric interventional cardiologist here at Maine Medical Center.
We want to thank the fellows for such a great case presentation. Just to briefly summarize, this was a 40-year-old woman with a history of Tetralogy of Fallot with surgical repair and a homograft pulmonary outflow tract surgical repair as a child, who then had a sapien valve 5 years ago, who presented to Maine Medical Center with cardiogenic shock. She had classical signs of right heart dysfunction, lactic acidosis, elevated right-sided filling pressures, and the team immediately started inotropes and diuresis, which was very appropriate. Either dobutamine or milrinone would have been appropriate in this setting. If she's more hypotensive or has renal dysfunction, then dobutamine would probably be preferred. In this case, she was started on dobutamine and Lasix. They did an echocardiogram which showed significant RV dysfunction, elevated gradients across the pulmonic valve. Attempts were made at a TEE, which were unsuccessful, but the team acutely and appropriately identified that the primary issue here was an issue in the right ventricular outflow tract. And at that point, given concerns for pulmonic stenosis and RVOT obstruction, the team appropriately sent the patient to the cath lab for further evaluation of the pulmonary valve. John, do you want to take it from there about what happened in the lab?
Sure. I think one of the interesting points was that her pulmonary stenosis gradient was not high by echo or in the cath lab. And that was simply a function of the fact that her right ventricular function was so poor, couldn't generate enough systolic pressure to create a gradient. So her output was exquisitely low. We shot an angiogram and there was a filling defect on the leaflets of the valve that I had actually placed 5 years previously. And so I did ICE imaging through her other groin. And I must say, it's one of the few cases I've ever done without any sedation or anesthesia because her blood pressure was so low at the time and she was hardly mentating. The ICU group did a great job getting her in fast. And the ICE imaging showed what looked like a big thrombus or a vegetation. And that was our filling defect on the angiogram. So at that time, despite her having no history coming in of fevers, we thought common things being common, this could very likely be a vegetation. So I was hesitant to put more hardware inside. So what I did was just balloon with a high pressure balloon, the existing Edwards Sapiens valve that was in there, and smashed the mass against the sides of the vessel. And in fact, we were able to do that with a repeat angiogram and with ICE imaging. We didn't alleviate all of the obstruction, but her blood pressure went up 25, 30 points as soon as we deflated the balloon, just making some improvement in the cross-sectional diameter of that outflow tract was good. And I sent her back to the ICU, and Bram, you can pick up about how her kidneys slowly recovered.
She slowly recovered from there. I think one of the big teaching points for listeners here is when you have a mechanical problem or an acute valvular problem, there's only so much that you can do for these patients medically. And really the treatment for these patients with an acute valvular issue or an acute mechanical issue is, either a surgical or percutaneous intervention. And so after this patient had an improvement in her RVOT obstruction, she slowly got better and was eventually discharged from the hospital on a course of empiric antibiotics for possible culture negative endocarditis, though there remain concerns about pannus versus thrombus. She was also anticoagulated. Unfortunately, despite her initial improvement in the ICU and discharge, she came back to the hospital about a month later, again in a very similar presentation in cardiogenic shock with lactic acidosis and transaminitis and markers of end organ dysfunction. And much of her imaging showed the same thing, which was severe RV dysfunction. She was again temporized with inotropes and sent back to the cath lab again.
The advantage we had the second time around is, I think, probably a dozen negative blood cultures, no history of fevers, no white cell count. We didn't hesitate the second time around to perform a valve-in-valve. And she had a 29 millimeter Edwards Sapiens S3 valve put in 5 years ago. So I just telescoped the second one inside. And then we were really able to smash that growth between the two stents. And ICE imaging showed a wide open outflow tract and a very competent valve. And I believe her recovery from that was a bit faster, and it's been durable.
Yeah, I think this was a great case about how the CICU and the cath lab, we can expeditiously move patients through that environment. And it also highlights, I think, some unique aspects of this congenital patient in that these RVs are conditioned over many years for pressure and volume overload. And then when you introduce an acute RVOT gradient, as in this case, the RV is so sensitive that the RV just falls apart. And you can put the patient on inotropes and you can diurese them, but unless you relieve that obstruction, it's not going to be a durable fix. So fortunately, in both her first presentation and second presentation, she was expeditiously brought to the cath lab and those interventions were performed. John, I'm curious what your thoughts were with the first intervention, given the question about pannus versus thrombus versus endocarditis, about doing a balloon valvuloplasty in that setting. I guess perhaps there was no other option given her extremis.
That's exactly right. Of course, I was thinking vegetation one. These valves in the pulmonary position just don't get thrombus on them. I think that was unlikely. And then organization of pannus over time. And I think that she's an interesting patient in that she stayed at home and gained 80 pounds of edema before she finally came into ER. So this was a slow accumulation of some mass occupying lesion in her pulmonary valve. I didn't want to embolize it. It was big enough that if it had embolized, it could have caused a PE insult, which is basically what was already the insult, proximal PE. But she was dying. Her blood pressure was in systolics in the 60s. She wasn't mentating, and there was no other choice.
Yeah. A really great decision to do that intervention in that acute setting. And oftentimes what we see in PE is even if you do an intervention for PE and there's proximal clot and it moves distally, sometimes the hemodynamics still improve. So you run the risk of some distal embolization of, vegetative material or thrombus, but still the hemodynamics may improve because some of that proximal obstruction would be relieved.
And by ICE imaging, it looked like a poster child for vegetation. So we were just trying to acutely open her outflow tract. And thankfully, she never grew a thing. And we were able to definitively open it a month later.
That's a great case. I think those are my big teaching points. Anything else from your end, John?
Just the point of, we were talking earlier about her PA pressure initially in the cath lab looked like a wedge pressure. And I've measured a lot of PA pressures in 3 decades. And it was simply because the pulsatility across the RV outflow tract that was partially obstructed with a very dysfunctional RV was so poor that it couldn't even generate pulsatile flow. And that explained the lactate that was through the roof and the creatinine that was elevated. 28 millimeter gradient is mild in my world. Most of the time, that's distal to a well-functioning right ventricle.
In many ways, this is how we think about low flow, low gradient aortic stenosis. The obstruction can still be quite severe, but if the ventricle can't generate, the gradients may be low, but it doesn't indicate necessarily mild valvular disease. It indicates a really sick ventricle.
Exactly.
Big thank you for Cardio Nerds for hosting this case. And we're pleased to present this case at a Maine Medical Center and to our fellows that put together a wonderful case here.
Yeah, so I think the punchline at the end is that this was a fairly rapid growth of pannus on the valve that caused a lot of problems. And when we were finally able to prove there was no infection, exclude it, she did quite well.
And now for a PD segment for this episode, I'd like to introduce Dr. Maxwell Afari. Dr. Maxwell Afari is an advanced heart failure and transplant cardiologist and the program director of the Cardiovascular Disease Fellowship at Maine Medical Center. He also has specific interest in cardio-oncology and infiltrative cardiomyopathy. He completed his medical school training at Pontifical Catholic University of Sao Paulo in Brazil, then went on to complete his residency training at Memorial Hospital of Rhode Island. He completed his cardiovascular disease fellowship training at St. Elizabeth's Medical Center and did his advanced heart failure and transplant cardiology training at the Massachusetts General Hospital.
Hello there. My name is Maxwell Afari. I'm the Cardiology Fellowship Program Director at Maine Medical Center. It is a pleasure to give you a brief statement about our fellowship program. Maine Medical Center, which is based in beautiful Portland, Maine, is the flagship hospital of actually a very complex healthcare system called Maine Health. And so many hospitals are associated with Maine Health, and we are the flagship hospital, approximately 700 beds. And we have 20 residency programs and close to 20 fellowship programs. And so it's definitely a huge learning institution. Part of the reasons why our fellows come here is one, obviously thinking about beautiful Portland. And being in Portland, Maine gets you closer to the waterfront. Portland is a very safe city and it's family friendly. And as most of Maine is actually called vacation land. And if you love food, and definitely it has a vibrant food scene. In terms of attributes of our program, Maine Medical Center has a huge volume and a high index of acuity. And just to give you general ideas of the numbers, approximately 1,700 PCIs per year, complex ablations, we're talking about over 1,200. Imaging-wise, about over 3,000 nuclear studies per year and over 21,000 echocardiograms. Fellows are very intimately involved in every aspect of care at Maine Medical Center and first call for any emergency or any cardiac complication. And the fellows are at the forefront in managing those patients. Aspects of our fellowship, which you would potentially love, include, you do get a lot of autonomy. And we do not have any subspecialty fellowship. When you are rotating on the electrophysiology service or the heart failure service or the interventional service, you are the EP heart failure or interventional fellow. So our fellows definitely a lot of autonomy. Other aspects of our fellowship, and we have these academic tracks, which you may not necessarily find in other programs. If you wanted to be a clinical educator, we do have a clinical educator track. And for those interested in data analytics, there's a clinical informatics track. There are also unique aspects of our fellowship, such as an opportunity to go down to Rwanda and East Africa for an international rotation. We have one fellow go down to Rwanda every year, and the beauty of it is to be very involved in their cardiology residency there and also advancing cardiology care in Rwanda. Also, what's unique to our program is we have a rural cardiology exposure, in which over the years our fellows appreciated, because you never know where you could end up working after fellowship, and having that unique skills of a rotation in rural cardiology gives you a lot of perspectives. In talking to our fellows, the things that our fellows love absolutely is the diversity of our fellows. Our fellows come from all across the country, and it doesn't matter whether you're an MD or DO, international medical graduate, or an American medical graduate. There's a lot of investment into your well-being as a cardiology fellow. And we are proud that every year we match 3 collegial fellows who get along very well. You should definitely check out Maine Medical Center. You can reach out to me. And as program director, my email is Maxwell Afari. Afari is AFARI @mainehealth.org. I'm always excited to talk to learners and trainees across the country about our program. Thank you.
Thanks for tuning in to another Cardio Nerds episode. The audio editing for this episode was performed by me, Tina Reddy. I'm an intern in the Cardio Nerds Academy House Thomas and fourth-year medical student at Tulane University. Check out the episode page for show notes and references. If you found this episode or the show informative, please consider subscribing to Cardio Nerds on your favorite podcast platform and leaving us a review. It really helps us spread the word and further our goal to democratize cardiovascular education. Finally, this podcast is not meant to be used for medical advice. The views expressed on our show and site do not reflect the opinions or policies of our employers. All Cardio Nerds content is planned, produced, and reviewed solely by Cardio Nerds. Stay tuned for more engaging conversations and explorations in our upcoming episodes. And now, it's time to make like an S2 and split.
Hey everyone, do you dread doing your notes every day? Do you feel like you can never get ahead of charting? If you're shaking your head yes, then keep on listening, because Freed AI is a medical scribe on a mission to free clinicians everywhere. Freed AI listens, transcribes, and writes medical documentation for you. So just imagine leaving your office at the same time as your last patient. Now, wouldn't that be delightful? Freed AI is HIPAA compliant, secure, and takes less than 30 seconds to learn. Team, artificial intelligence cannot replace you, but it can do the administrative work that will allow you to spend more quality time with your patients and enhance your personal work-life harmony. So get back to doing what you love, helping your patients, and let Freed AI do the rest. Check out www.getfreed.ai to learn more.